morning, everyone. Welcome to our webinar today. Thank you for joining us. My name is Corinne Pope. I'm a coordinator here at of Patient Safety and Quality at the MHA Keystone Center. So today our webinar is going to be titled Operationalizing Outpatient Antimicrobial Stewardship. If I could talk, it would be helpful. So today's webinar is actually being hosted jointly by the MHA Keystone Center and MPRO. So we have invited hospitals that are part of the Hospital Improvement Innovation Network, so the HIN, and also the Lake Superior Quality Improvement Network, the LSQIN. So we have members here from across 4 states, Michigan, Illinois, Wisconsin, and Minnesota. Because AMS has become such a big topic, and there are so many events coming up with relation to AMS, such as Get Smart Week, which is going to be hosted in November by the CDC. We were hoping that this webinar would help start the discussion and reduce some of the confusion around AMS. So before I introduce our presenter, I just want to give you a couple of quick housekeeping rules. So first would be to please don't put us on hold, as we will be disrupted by your hold music. There is a chat option in the bottom right corner of your screen. If you want to write any questions during the presentation, we will be holding all questions until the end. And then at the end, when we have time for questions, you do have a raise hand option that you can press, at which time we will unmute you, and then you can speak directly with our presenter. Also, our presentation, as always, is being recorded, and it will be posted to the community site once it's available, along with the slides. However, because we do have organizations from 4 different states joining us, some may not have access to our community site. So whoever is on today's webinar, we will be sending you the slides directly to your email after the event. So with that being said, I'm going to introduce our wonderful presenter today. We have Michael Klepser, who is a PharmD from Ferris State University. Dr. Klepser received his Doctor of Pharmacy from the University of Michigan College of Pharmacy in 1992. He has also completed a pharmacy practice residency at Detroit Receiving Hospital and University Health Center, and a fellowship in infectious diseases at Hartford Hospital in Hartford, Connecticut. Dr. Klepser has been a professor of pharmacy at Ferris State University since 2001. And prior to joining Ferris, he was an associate professor at the University of Iowa College of Pharmacy. Dr. Klepser's research interests include use of point-of-care tests in community pharmacies, community-based antimicrobial stewardship, antifungal pharmacotherapy, antibacterial antifungal pharmacokinetics, influenza, and health economics. He has also published extensively on these topics and has more than 130 peer-reviewed manuscripts to his credit. Dr. Klepser is a founder and content advisor for the community pharmacy-based point-of-care testing certificate program. Dr. Klepser is active in several professional organizations, including the Society of Infectious Diseases Pharmacists, the American College of Clinical Pharmacy, and the Infectious Diseases Society of America. So thank you for joining us, Dr. Klepser, and the floor is yours.
Thank you, Corinne, for the introduction, and thank you, everybody, for dialing in for the presentation. Outpatient antibiotic stewardship obviously is something that has gained a lot of attention over the last few years. And I think it's important for us to start to consider what that actually means and how to go about starting to implement stewardship in the outpatient setting. You know, at this point in time, we're all familiar with the inpatient setting, but with the outpatient, there's a variety of challenges that are kind of unique to that practice site. And I'm going to discuss a few of those today, as well as talking about perhaps how to maneuver around some of those potential barriers. First, I would like to say that I'm really not going to be discussing any products today that are going to constitute any real or perceived conflict of interest. For the objectives today, you know, again, just a high-level overview of antimicrobial stewardship, as well as talking about, you know, some potential interventions in the outpatient community. And I'm going to spend some time talking about quantifying and assessing antibiotic usage in the ambulatory care setting, because really without a means to do that, we're really at a loss in terms of how to measure the effectiveness of our interventions, or even to determine where we should be focusing our efforts. So just a little bit of background to lay the foundation here. You know, in the United States, there's approximately 450 million office visits every single year for primary care, internal medicine, family medicine, pediatrics. And roughly 150 million of these result in the prescription of an antibiotic. And this is a fairly decent percentage, you know, when you think about it. And knowing that we've spent a lot of time in the past looking at inpatient use of antibiotics, I think it's pretty astounding to realize that the majority of antibiotic use does occur in the outpatient setting. We're not going to talk about, agriculture or, farming. We're just going to talk about human use. And about 60 to 80% of all antibiotic use for humans occurs in the outpatient setting. And unfortunately, there's an incredibly high rate of inappropriate use in the community setting. It's been estimated that for some disease states, inappropriate use occurs at least 60 to 80% of the time. If we look at national averages, you can see on this slide that there's quite a difference with respect to the states and their antibiotic prescribing. These data were published in 2013 and probably reflect about a 2012-11 data. And these are looking at antibiotic prescriptions per year per 100,000 individuals. And the national average over that time was about 833 antibiotic prescriptions per 1,000 individuals per year. So you can see that's quite high. And the states that we're looking at, Michigan, we haven't done really good in terms of controlling our antibiotic use. And to put this number in perspective, we're going to talk about probably some Scandinavian countries that have reduced their antimicrobial utilization to roughly 525 prescriptions, antibiotic prescriptions per 100,000 or per 1,000 individuals. So we've got quite a bit of way to go to get down to those more tolerable levels. When we look at who's prescribing the antibiotics, it really should not come as a big surprise. Primary care physicians are the individuals that are prescribing most of our antibiotics, along with nurse practitioners and physician assistants. And this is important to point out because everybody's looking for somebody to blame. And you get a group of folks together, physicians and whatnot, and they always blame the dentists for some reason. The dentists don't know how to use antibiotics. There's this big overuse of antibiotics in dentistry. Well, that might be the case, that there's some room for improvement, but in general, dentists only account for 9% of the antibiotic use, in the outpatient setting. So, if you were going to, rank where you wanted to spend your efforts, dentist is probably not going to be the place where you're going to start out with, because you're not going to get the biggest bang for your buck. So, it has been estimated that as much as 50% of the outpatient antibiotic use is inappropriate. And that's a very conservative number. And when I say inappropriate, it doesn't mean just the wrong antibiotic for an indication or using an antibiotic when it's not indicated. I'm also talking about the wrong dose, the duration. And that's one of the big things. We've done some studies in our clinic, and we find that for something like acute pharyngitis, our clinicians choose the correct antibiotic approximately 95% of the time, at least according to published guidelines. However, they're using too long of a duration or too high of a dose of antibiotics, probably at least 85% of the time. So there's a number of things that we have to consider when we're gauging the appropriate use of antibiotics. Now, we also do need to recognize that there's a tremendous amount of overuse for antibiotics for indications where really they're not indicated. And in one study, looking at residents of a nursing home, about 50% of the residents got an antibiotic for a common cold, which just is, almost can't even conceive that in this day and age why that would be appropriate. And if we look at some data from the Pew Charitable Trusts, they looked at data from the United States, and they found that in the United States, the percentage of visits for colds that resulted in antibiotic prescriptions was about 68%. 68% for a common cold. So we got a problem. And when they looked at prescribers, those that prescribed antibiotics, the most really prescribed antibiotics a lot of the time. And for the top 10% of individuals, those highest prescribers prescribed antibiotics for about 95% of their visits, where those in the lower 10% only about 40% of their visits. And, you could argue there's different patient mixes and stuff like that, but really that type of disparity tends not to be what we really find. If we look at some of the common indications where antibiotics are being used in the United States, yeah, we have been making some inroads in improving antibiotic use. These are data looking from the mid-90s to the mid-2000s for a variety of infections. For ear infections, right now kind of the standard is this watchful waiting. We know it's self-limiting in a lot of cases, but still, we're prescribing antibiotics in roughly 70% of the patients, and that's down about 7% from the mid-90s. For the common colds, hey, we're down from 52% in the mid-90s to about 38% in the mid-2000s. So, yay, we came down about 20%. But still, almost 40% of individuals are getting antibiotics for the common cold. So that's really nothing to, get too excited about, because there's still a lot of work to be done. And if we skip down to the common cold, or skip down to sore throats rather, these are data for pediatrics and adults together. If we looked at just adult patients, we've got about 3 decades worth of data that show that adults that go to their primary care provider for acute pharyngitis, that about 60 to 80% of those adults come away with an antibiotic. Well, what we need to understand is probably only about 5 to 15% of those cases are actually infected with group A strep. And that's the only pathogen that causes acute pharyngitis for which we should be treating, or for which treatment's recommended. So there's a great discrepancy with acute pharyngitis that has been very well documented. So which infections rather do we see the most misuse of antibiotics? And they're the ones that you're going to expect. Upper respiratory tract infections, these are infections for which we have a lot of viruses causing infections, and historically our diagnostics have not been fabulous to differentiate here. Urinary tract infections, pneumonia, skin and skin structure infections, these are all very commonly encountered conditions in the outpatient setting, and areas where we do see a lot of inappropriate use of antibiotics. But why? Why do we have this misuse of antibiotics? And the one thing that, people always go to is the patient, when they come to see me, they expect an antibiotic. And so because of that, you talk to physicians and whatnot, and they'll admit, we're people pleasers. We want to make people happy. And people are going to be happy when they get an antibiotic. And if I don't give them an antibiotic, they may just go somewhere else. Well, that mindset, the validity of that has been challenged, and I think a lot of that is starting to crumble away. There's a lot of good studies now looking at patient satisfaction with healthcare, and patient satisfaction with healthcare is not related to receipt of a medication. Patients want to be heard. Patients want to know that somebody cares about them and takes the time to listen to them, and that's really what drives patient satisfaction, not necessarily receipt of an antibiotic or something like that. Also, we have lack of adherence or familiarity with treatment guidelines. And, I don't want to be overly critical of anybody practicing medicine because there are literally hundreds and hundreds of treatment guidelines out there. And it's impossible for one individual to stay up to date with all of these guidelines and practice at, at the most current level. But it is a problem. From my perspective, I took my daughter, 3-year-old daughter, to the pediatrician, and she was seen by a nurse practitioner. My daughter had recurrent otitis media. Initially, she had received a cephalosporin. Then 3 months later, she received a macrolide, and now I'm coming back in for the 3rd time. And the provider, looked at her records, looked at me, and said, "Okay, now we use Bactrim." And I said, "No, we don't use Bactrim." And she said, "Yes, we do use Bactrim in cases where we have recurrent otitis media and they failed all these." And I said, "No, we don't." And she said, "Well, who are you?" And I said, "Well, I'm a pharmacist who's trained in infectious diseases." And her response was, "Well, children are different." And, I think that she was trying to do the right thing, but somewhere along the way, she got a misconception in terms of how treatment, in that case needed to occur. So I'm not being critical of her familiarity with the guidelines. It's just there's an opportunity there for education. One of the other things is this lack of use of diagnostic tools. and microbiology data at the point of care. In the inpatient setting, we have all these wonderful rapid diagnostic tools, MultiTOF, everything else that gives us information about the cause of the pathogen, fairly quickly. And in that setting, we also have the luxury of the patients there, so we can do cultures, and we can wait to see if the cultures come back positive and all this. In the outpatient setting, we need data, and we need it within 5 or 10 minutes. Otherwise, the patient leaves, and we don't really have the ability to follow up or change things. And, with respect to the diagnostic tools, they're changing. The technology is evolving very quickly, even to the point where there are now CLIA-waived point-of-care tests that do real-time PCR. So you can get PCR results in less than 20 minutes for patients. So that's pretty reliable. But the other thing that we do see for even things that are still of relatively good value, even like a strep test, there's a lot of misconception of what the value of those tests are, or what their performance characteristics are. For most of the widely used rapid strep tests, the sensitivities are probably in the low 90 percentages, and the specificities are in about 98%. So these tests do perform well, but still a lot of the time we have clinicians that run the test and they say, well, I just don't believe the results of the test, so I'm going to give you an antibiotic anyway. Well, if that's the case, one, why are you running the test? Because we're wasting time and dollars. And two, if you do run the test, why not follow the results? There obviously are provider shortage issues. There are a lot of pressures to see patients. In my clinic, providers are scheduled to see patients, roughly every 8 minutes. So things do need to keep moving along pretty quickly. And rather than wait for the results of a test or the patient to go to a lab and come back, they give, antibiotics. And it's just easy to write that prescription. And that kind of ties in as well with poor patient follow-up. There's a mindset a lot of the times that once we see a patient, make a decision, and initiate treatment, we're done. And realistically, probably what we should be doing a little bit more often is having some sort of at least telephone follow-up for patients. If there is a self-limiting condition for which antibiotics may not be appropriate, why not call the patient 24 hours later to see how they're doing? If they're still not doing well at that point in time, maybe then there's a need for the antibiotics. Maybe then we can phone in an order. And so we need to look at those type of programs. I'm sure you guys have all seen some of these pharmacy programs where they have free antibiotics. And I think these programs were really created to help remove some of the barriers for patients from getting antibiotics and not to withhold treatment from people. But unfortunately, by removing that barrier, I also think that they've created this artificial formulary, because some prescribers are aware of these free programs. So they'll use these antibiotics that maybe are not necessarily recommended for an infection and might be suboptimal because they're free. And they know then that the patient will be more likely to get the prescription filled. Also, there's maybe a reduced threshold from the prescriber then with respect to prescribing that antibiotic, because they know cost isn't an issue. So if they're concerned, the patient I know is on Medicaid or whatever, or Medicare, has a fixed income, well, if I prescribe one of these antibiotics, it's no money out of their pocket. So that's okay. And this is creating some problems perhaps with the overuse of these free antibiotics. And then lastly, there's this fear. There's fear of missing something. I mean, we all want to do well. We all want to plan for every contingency. But that's not necessarily the most appropriate use or most judicious way to practice medicine. And unfortunately, we've got a lot of lawyers in this country. And I think that that puts the fear of litigation into the minds of a lot of clinicians. And again, fearful that they don't want to miss anything. So what's the problem? What's the problem with overusing antibiotics? There's actually lots of problems. I mean, one of the major problems is resistance. There's been a lot of studies worldwide that have looked at antibiotic utilization and rates of use and very, very eloquently correlated antimicrobial consumption with rates of resistance. So we're losing these agents that we need to use to treat life-threatening infections. Also, this resistance, it's not just a matter of having to pick a different agent or a more expensive agent. There's real morbidity and mortality that's associated with the resistance. There's increased rates of mortality because we're not getting the antibiotic right the first time. We all know that from the inpatient side, that mortality and patient outcomes are linked to how quickly you can get them the appropriate antibiotic. And so that could be, greatly delayed in the outpatient setting. Also, there's cost. Every year, it's estimated that there's over $13 billion in excess treatment costs that are associated with, treating antimicrobial resistant bacteria. The other thing that I think a lot of clinicians do not appreciate are the safety issues. There's this perception that, antibiotics are relatively safe, so therefore there's very little risk to the patient of prescribing them an antibiotic, even if we're not really sure they need it. And that's a mindset that we need to change. There's been several studies that have looked at side effects or adverse reactions that are associated with antimicrobials. And in terms of drug-related adverse events, the adverse effects associated with antibiotics are the most common drug-related causes for emergency department visits among pediatrics. And among all age groups, the adverse events are associated with 1 out of every 5 drug-related emergency department visits for all patients. So there's a significant safety issue here, whether it's from a rash, hives, anaphylactic reaction, Clostridium difficile infections. There's a variety of things that can occur negatively in our patients because antibiotics were administered, whether appropriate or inappropriate. And so because of that risk, we need to be looking at minimizing patient exposure to minimize the risk for these adverse events. Getting back to stewardship, again, we've all been familiar with antimicrobial stewardship on the inpatient side. It's been around for several decades, and we know the value that we've seen with antimicrobial stewardship programs in an inpatient setting. We've seen the reduction in inappropriate use of antibiotics. We've seen some decreased antibiotic expenses, and improved patient outcome, and perhaps even some improvement in resistance profiles. So now the question begs to be asked, why haven't we done anything in the outpatient setting? And, simply put, it hasn't been sexy. These ID-trained folks, they've been running around in the hospital dealing with ICU patients, dealing with, the cancer patients on the inpatient side. Most ID-trained individuals do not practice in family medicine or internal medicine clinics. This has not really, raised to the surface of importance for them. And so because of that, we've got a lack of trained and or interested individuals in the outpatient setting. The structures of clinics versus hospitals, if you have a prescriber who is prescribing a restricted antibiotic in the inpatient setting, you can track that and you can say, hey, that use is costing the hospital money. We'd like you to stop. Otherwise, we can do something with your, prescribing privileges or your practice privileges. On the outpatient setting, most of the time, ambulatory care sites really have no skin in the game with respect to what antibiotics prescribed. The patient or the physician writes the prescription, and the patient gets it filled wherever they want. So there's really not that incentive from that perspective, to rein in the inappropriate use. And from that, perspective as well, historically, we have not had a good way to track antibiotic usage in the community on a real-time or localized basis. Well, it's important to understand that things kind of changed a little bit back in 2014, 2015, when the White House put out the National Strategy and National Action Plan for Combating Antibiotic Resistance. And some of the key things that they attempted to focus on was slowing the emergence of resistant bacteria and prevent the spread of resistant infections. And one of the primary things that they said was antimicrobial stewardship. We need antimicrobial stewardship in healthcare settings and in the community. So right here they were saying, okay, it's no longer enough just to focus on the inpatient side. You've squeezed that balloon, you've tightened it down as much as you can, but we still got resistance. You can keep control of your antibiotics in the inpatient setting, but patients are being admitted from the outpatient setting. They're coming in with resistant pathogens, and they're still, difficult to treat. And those resistant pathogens are now spreading widely in the community. One of the primary goals that came out of the action plan was that by the year 2020, they called for a reduction in inappropriate outpatient antibiotic use by 50% by 2010 levels. And if you just stop for a minute, they're saying cut the inappropriate use by half. Wow, that's 50% is a big number. But then you look, 2020, those, in my mind, those are those like space odyssey, walking on the moon or Mars kind of numbers. And then my wife always has to remind me now that we're almost in 2018, so we're getting very close, almost 2 years, only 2 years away from 2020. So that's not as far off as we thought. And then you got to step back and you got to think, if I asked you, how many antibiotics were used in your clinic in 2010? Could you tell me? Would you even know where to start to look? And then beyond that, we need to look at the inappropriately used antibiotics. Do you have any way to tell me which antibiotics were appropriate or inappropriate, and who is prescribing them, and how to detect problems? In most instances, no. You go to a clinic and they have no clue how to give you those type of data. So, before we even really talk about stewardship at all, this is the fundamental problem. We need to be able to identify how to assess and monitor appropriate use of antibiotics in the outpatient setting. The second thing with respect to some of the goals is looking at surveillance. And historically, we have not done a great job at tracking surveillance or tracking resistance in the outpatient setting. We don't have good culture data. We don't routinely culture patients in the outpatient setting. But again, I mentioned technology. Technology is changing. I can do real-time PCR, off a finger stick of blood to tell you if, MEC or some other resistance determinant might be present. So there's going to be ways to do this, but we have to do it in a meaningful way and not just order tests just for the sake of ordering tests. Those rapid diagnostic tests that I mentioned, there's a realization that, yes, clinicians historically have not felt comfortable with some of these tests because of their performance limitations. But now there are data, good data, multiple studies that show that these diagnostic tests do a better job at identifying patients with viral and bacterial infections and distinguishing between the two than clinicians do. There was a study that was published looking at emergency room physicians and their ability to diagnose patients with influenza using influenza-like illness criteria versus using a rapid diagnostic test. The patient or the physicians that base their diagnosis solely on influenza-like illness criteria only got the diagnosis correct about 30% of the time. Individuals that used the clinical judgment in conjunction with a rapid test got it right at least 60% of the time compared to a PCR control. So there was a significant improvement, when they were utilizing those tests. So we need to develop not only more tests, better tests, but help get clinicians used to believing the results and utilizing those data. So last year, 2016, the CDC published core elements for outpatient antibiotic stewardship, and they added these core elements to their already existing core elements for inpatient and long-term care. And what they proposed mimicked or mirrored the other core elements, fairly closely in terms of, needing commitment. People need to dedicate or demonstrate their dedication and accountability for stewardship. They need to take action. They need to track and report, and they need to educate and use expertise. And some of the proposed actions that they did, and they proposed them at the clinic system and the clinician level, their interventions, and they looked, primarily they said, okay, you know what? Antibiotics are only used in sick patients. So if we can prevent patients from getting sick, this is probably one of the best means of engaging in outpatient stewardship. So promoting immunizations, hand washing, looking at appropriate use of antibiotics, having knowledge of resistance profiles, in the community, so we're using our antibiotics optimally, engaging in antimicrobial stewardship, and promoting the development of new antibiotics and diagnostic tests. Those were the primary actions that they proposed. The one thing that I believe that they forgot is to focus at interventions on the patient level. We've gone too long with this idea that our care is patient-centered but provider-led. In reality, nothing could be further from the truth. Healthcare is patient-centered and patient-led. Patients are going to do what they want. Patients are in charge of their own healthcare, and they make the decisions, regardless of what we tell them or request them to do. So we really cannot forget to engage the patients when we're talking about outpatient stewardship. Some examples of interventions that were proposed by the CDC related to commitment. These are the written displays of commitment. So clinicians signing a poster, telling patients and showing themselves on a daily basis, we are committed to improved care through the appropriate use of antibiotics. From the clinic level or health systems level, put your money where your mouth is. Identify somebody who in their job description takes responsibility for antimicrobial stewardship. From the action and policy level, on the clinician side, make sure people are using evidence-based diagnostic criteria and treatment recommendations. Yes, I appreciate that medicine is an art, sometimes it's not a science, but the majority or a lot of patients still fall into those buckets of norms rather than outliers. We also, from the clinic and health systems level, help clinicians be better equipped to engage with patients and talk to them about why antibiotics are not appropriate. Help them to stand their ground or use some sort of accountable justification. Make them, put in an indication for why that they had to use or a justification of why they had to use an antibiotic that maybe not have been recommended by a treatment guideline. And those types of activities, especially when they know they're being held in comparison to their peers, become quite effective. Obviously, we've got some tracking and reporting things, and you can see, those interventions or actions there. And then education and expertise. Now, I will say that one of the things that we have found over time is that educational efforts, the impact of educational efforts when done alone or just as little in-services tend to be relatively short-lived. So this should not be the primary area that you focus in on. We really need to look at changing behaviors of clinicians, health systems, and patients, and education is only a small piece of that. I think everybody's aware now that as of January 2017, that JCAHO requires that all inpatient facilities have some antimicrobial stewardship activities occurring in their institution. You should be aware also that JCAHO is currently, when those core elements were developed, members from JCAHO were in the room when they were being developed. And, they were asking questions like, so what can we do to help? Do you want, should we be developing carrots or sticks to promote these? So it's on their mindset, and they will be developing antimicrobial stewardship practices for ambulatory care and office-based surgery practices. And the Accreditation Association for Ambulatory Healthcare has shown indications that they are likely to expand some of their accreditation criteria into the antimicrobial stewardship area as well. So the problem with stewardship or outpatient stewardship in terms of identifying some good practices and interventions is we're still learning what's appropriate, what's good use in the outpatient setting. There are really no formal guidelines or structures or methods to say, okay, this is who serves on your team. And realistically, one of the biggest problems is there's no standardization regarding determining and reporting antibiotic utilization and appropriateness of antibiotic use. I want to call to your attention two papers that were recently published by the Society of Infectious Diseases Pharmacists, and they were just published this past spring. And these two papers really looked at raising awareness of the need for outpatient antimicrobial stewardship. And also they kind of outlined the process for developing a program, helped to identify key stakeholders and team members. I proposed a few means for quantifying antibiotic use and to assess appropriateness of use, and reviewed some of the data surrounding some of the interventions and activities. So this is a good place, I would recommend to start is with these two papers. And what they recommended in these papers for a team is they recognize that not every clinic or not every outpatient facility is going to have people that are highly trained or especially trained in infectious diseases. What they suggest is identifying core members of this team, likely an ID-trained pharmacist and or physician. Perhaps these are individuals who are practicing on the inpatient side of the health system to help lead the team with respect to identifying policies, identifying procedures, identifying potential interventions, and leading kind of from that policy standpoint. And then teaming them up with translational members, people on the ground, if you will, in the clinics, people that would be responsible for the day-to-day operations for promoting stewardship. They'd identify these translational members, obviously needing somebody in the clinic to take a lead and have responsibility for stewardship efforts. That's going to be key, because if nobody's being responsible or nobody takes responsibility, you guys know these things don't get done. Also, need to have cooperation or on your team a microbiologist or a laboratorian, somebody who understands the value of the various tests that are there in those clinics. And they possibly should be coming up with algorithms for patients when you should use various tests. Almost a stepwise approach. Use a rapid test. If that doesn't work, or if you're still concerned, go on to something else, not necessarily always jumping to the most expensive test or relying on clinical judgment. And obviously, information technology specialists are going to be key. We need to access data. And at this point in time, these are data that we have not necessarily always looked at in the past. Another thing that needs to be considered is the scope of outpatient antimicrobial stewardship. And the easiest way to form a program is to look within a single institution, either a single clinic or a single healthcare system. It's easier to get those team members together. However, if you really think at getting the maximum impact of stewardship activities, you really need to look beyond that. Because unlike the hospital, where patients really don't go from hospital to hospital all the time or walking around from unit to unit very often, in the community, these patients are circulating all over the place. So your patient that comes to your clinic might also be going to a daycare and being exposed to bacteria. They might be going to a nursing home. They might be going to work. And so we have a reason to want to spread stewardship throughout the entire community. And that's a little bit more difficult to get your heads around, but we'll talk a little bit about that in a moment. The other thing, since what we're trying to accomplish in the outpatient setting has been done to some extent on the inpatient side, and there's expertise, and the individuals on the inpatient side do have a vested interest in keeping resistance in the community low, because then those resistant bugs don't get into the hospital, look for teammates or leaders from the inpatient team to help with engagement in antimicrobial stewardship on the outpatient setting, because it is in their best interest as well. So when you're going to start to develop that stewardship program, obviously you got to figure out what your scope is. Is it an institution? or is it community-wide program? And that's going to help you identify who your stakeholders are and who your team needs to include. And then you need to develop or identify the team members. You need to assess the baseline practices in antibiotic use before you start talking about initiatives. Because if you say we're going to do an educational program on urinary tract infections, and you have no idea if the antibiotic utilization is inappropriate or what the inappropriateness is, your initiatives might be a waste of time. Once you know your baseline practices and develop program priorities, then you develop the initiatives, and then you develop a system for monitoring progress and outcomes. So, underlying to all of this, and as I mentioned before, and one of the most common outcomes, or the easiest outcomes on the inpatient side that we've always looked at, is antibiotic use. And we'll use things like days on therapy, defined daily doses of antibiotics. And we're able to do that because we have purchase data and dispensing data right there in the hospital from the pharmacy. It's easy to get those data. On the outpatient side, we do not have purchase data because, again, remember that patient can go anywhere in the community to get the prescription filled. So it's difficult to get utilization data with respect to antibiotics. Now, we can look at payer databases. We could look at a variety of regional type of databases, third-party payers, as well as wholesalers, but those data generally lag. We don't get them in real time. And when we get them, it can be relatively difficult to narrow it down to give us enough data to develop our interventions. And then it's very difficult for, in a timely manner, to assess whether or not our interventions worked. So we need a better way to do things. And probably one of the best ways to go about monitoring antibiotic use is to use data that you already have, data that's in your electronic medical records. Now, I know that you don't have necessarily data about consumption, so you don't know if the patient actually took an antibiotic. But you do know if a provider prescribed an antibiotic. And by identifying prescription patterns, you actually get an insight into the provider mindset in terms of who they would prescribe antibiotics for. And with that, you can identify, once the antibiotic has been identified, you can link that back, and a lot of your electronic medical records do that already, link it to an indication. So you can tell what they're being prescribed for. Then we promote using this concept of prescribed therapeutic regimens and recommended therapeutic regimens to get an idea if the dosing for the antibiotics was appropriate. And we define appropriateness based off of guideline recommended therapies and dosing regimens. So to calculate a prescribed therapeutic regimen, essentially what we're looking to do is get a marker or a quantification of antibiotic exposure. And so we do this by multiplying the antibiotic dose by the frequency that it's administered times the duration, and we can get a value. We can then look at published guidelines and calculate a similar parameter called the recommended therapeutic regimen. And since there's a number of dosing regimens sometimes that are recommended, we calculate a recommended therapeutic range, or a recommended therapeutic regimen range. So you have a max and a min. And then you can compare the PTR to the RTR range for an individual patient. And if the PTR falls within that range, then that would be considered to be a appropriately dosed antimicrobial. If it falls outside that range, then you could classify it as inappropriately dosed. Also in here, you can link patient encounters to GFR, serum creatinine, hepatic function, whatever, to get correction parameters for renal function and stuff like that, as well as looking at appropriateness based on patient allergies also. So like I already kind of ran through, the processes that we've used is identifying that episode of antibiotic use, pulling out the information surrounding that episode related to the diagnosis based on ICD codes around that area, that date range, We can look at laboratory data, allergies, collect the information regarding the prescription, the dose, duration, frequency, and stuff like that, and then compare the data that we've got. And just to kind of show you how this all plays together, I've got a case here. And we've got a patient who was identified that had received a prescription for amoxicillin on December 12th. And for this episode, they were prescribed 1,000 milligrams of amoxicillin daily for 10 days. And the ICD-9 code at that time was 34.0, which was streptococcal sore throat. The patient did not have any drug allergies and had normal renal function. It was noted that around this encounter, no diagnostic laboratory test had been ordered for the patient, and we were able to identify the prescribing provider. According to the published guidelines, amoxicillin is recommended for the treatment of streptococcal pharyngitis, so it is an appropriate agent. And there are a number of dosing regimens, either 500 milligrams twice a day or 1 gram once daily for 10 days that are recommended for the treatment. And calculating that the RTR for each of those, the 500 times 2 times 10 or the 1,000 milligrams times 1 times 10, both of those give us a value of 10,000. So the RTR range for amoxicillin for streptococcal pharyngitis in a patient with normal renal function was 10,000. For this case, the prescribed therapeutic regimen, or the PTR, appeared to be appropriate, 1 gram once a day for 10 days, so the PTR was 10,000. So for this case, the choice of antibiotic was appropriate and the prescribing regimen is appropriate. However, then we always start thinking about the diagnosis. And was there a coding bias? And we know that only 5 to 15% of adult patients with acute pharyngitis have group A strep. And in this case, since no diagnostic tests were performed, you might wonder how that diagnosis was made. You could go back and you could look to see if a Centaur score was calculated, which is generally not recorded in the chart. But even if that was the case, most of the time it's recommended that a Centaur score of greater than 2, or 2 or greater rather, are followed up with a rapid diagnostic test, which is recommended by the guidelines. So the failure to use that test would have been an area for intervention and education. And you could see how often that were to occur in the clinic. Or you could look at how often the test was run and the results came back negative and antibiotics were still prescribed. And so again, those are ways to identify opportunities for intervention. Obviously, the value for engaging in this type of exercise, should be relatively obvious. Establish the baseline. You need to know where you start before you can determine the impact of your interventions. So then you can monitor the effectiveness and durability of your interventions. You can also look at prescribing rates and you compare them to national or regional values as well. And by using electronic medical record data, it's stuff that's already there, and you can create extraction algorithms that allow you to pull data fairly frequently, and you can almost get these data in real time. And we've been working on creating dashboards interfaces for a variety of EMR interfaces. So the prescriber periodically be able to go in and look at, compare their rates of prescribing antibiotics for various indications to other, prescribers, or just look at, globally how the practice is doing. Advantages, I've already run through some of the advantages of using data from your ENR. Depending on the EMR system you have, it can be a pain in the butt to get the data. I know that the original system that my clinic was using was, I swear, must have been made in somebody's garage, and it was a very difficult process to get data. I know that using Epic and Cerner, it becomes a lot easier. So it just takes some experience in terms of what data fields you're going to pull and how data are stored in those data fields, whether they're text or numeric. Obviously, text fields are going to be problematic, especially if there's free text ability and people are misspelling words and whatnot. So it might just take a little manipulation with the data to clean it up. by even just simply starting to look at how antibiotics are being used in your clinic, you know, it's going to help meet goals 1 and 2 of the White House Action Plan. So it's the first step of starting to solve this problem. We need to understand our problem with antibiotic use before we can look to correct it. I've already mentioned the interventions, and I'm not going to go through all the interventions that have been looked at. The CDC published an appendix to their core elements. So if you just look at the core elements, it looks kind of like a weak document. You know, you're looking for the meat. And the meat actually comes in these appendix where they review all the published interventions that had been out there at that point in time. But again, if you really want to make an impact on resistance rates and stewardship, I think you got to look bigger than just your system. Look bigger than just your clinic or clinic system. And you need to really think about what's going on with the patient. And the way I do that is I like to think of an infection as a cycle, a cyclical process for the patient. Initially, the patient is at baseline health. This is where we'd like the patient to, you know, not only start but end up. And our real goal is to keep the patient well. So by promoting wellness initiatives, that can be a very powerful stewardship tool. There was a study that was published by Catherine Fleming-Durta and colleagues looking at antibiotic use in ambulatory care settings. And I thought it was just really interesting, an observation that they made, where they said the primary risk factor for a patient to receive an antibiotic was going to their doctor's office. And the more times they went to a doctor's office, the more likely they were to get an antibiotic. Now you stop and you go, duh, I mean, that's the only place they can get an antibiotic. But if you're thinking about all the reasons why patients go and, you know, all these acute illnesses that, you know, could mimic a treatable infection, you know, we really want to keep the patients away from providers, because then you decrease the risk of using an antibiotic. So some of the things we can do: promote immunizations, promote wellness initiatives, keep those patients healthy. So let's say that fails and the patient actually does get sick. The first thing that they do is they go, I'm sick. And again, what can we do at that point in time? We need to educate patients. Not every infection is bacterial. Not every infection requires going to the doctor or getting an antibiotic. So education or consultation with a pharmacist or a nurse or a triage person in the clinic might help prevent unnecessary you know, visits to the clinic. Well, the patient at that point in time is going to either abide by that information, or they're going to decide, you know, I am actually sick enough to go see somebody. And where would that be? You know, initially, they might not even think about going to the prescriber's office. They just might go to a pharmacy. They might be looking for something to self-treat themselves. They might be getting, you know, zinc to combat a cold, or vitamin C, or maybe they're looking for Motrin. And if we're able to identify these patients early on, and even manage some of these patients with self-limiting illnesses in the pharmacy, again, we're keeping patients out of the clinic. And even in some of these collaborative practice models that occur in pharmacies, we've done studies where the pharmacist will do an evaluation, a physical assessment, and they will practice under a collaborative practice agreement. And based off of their findings, they would be authorized to perform a rapid diagnostic test, let's say for group A strep. If that's positive, under that collaborative practice agreement, the pharmacist could theoretically then dispense an antibiotic. If the group A strep is not present, they are not authorized to dispense an antibiotic. So if that test is negative, there is no wiggle room for them to dispense an antibiotic. So they, you know, truly practice evidence-based medicine in that setting. Regardless, at some point in time, we might decide, okay, patients here, we've seen them, we got to use antibiotics. Now we need to figure out how to influence antibiotic use, whether that's through prescriber education, using appropriate diagnostics based on community algorithms, accountable justification, audit and feedback. there's a variety of elements or initiatives that we can engage in this area, and a lot of these really are focused on the providers at that point in time and not necessarily the patient. The next step in this process is actually getting the antibiotic. So here, we can have the pharmacist looking at the antibiotics that were dispensed. If we have an indication, they can double check the appropriateness of the antibiotic and the dosing regimen. At this point in time as well, we should be promoting immunizations. Sick people feel horrible. They don't want to be sick again. And so that we know that this is an opportunity to promote things like influenza vaccinations, pneumococcal vaccinations, a variety of other things that actually can be administered to the patients, while they may be undergoing the acute illness at the present time, and we can probably have a better uptake on our immunizations by taking this approach. And lastly, post-encounter care. This is what patient satisfaction, what drives that. Talking to the patient afterwards and just saying, hey, how are you doing? I know we didn't prescribe an antibiotic, so I just want to double check to make sure you're okay. And this then can be used to support delayed prescribing, because if the patient's still sick, perhaps now you dispense an antibiotic. And it also serves as a safety net. If the patient's not getting better, even if you put a patient on an antibiotic appropriately, there's a subset of patients that are not going to respond because of resistance or something else. So this can help identify those individuals before they get critically ill, and patients can then be triaged to the appropriate site of care. I mentioned those acute pharyngitis, and just want to highlight a couple of the projects that we did surrounding that. So we had a model that we piloted in 55 pharmacies in 3 states, where pharmacists and physicians engaged in a collaborative practice agreement that allowed the pharmacist to identify patients with acute pharyngitis, conduct a physical examination, offer a rapid diagnostic test for group A strep, and then dispense an antibiotic if that test were positive. What we found is that only 20% of the patients that came to the pharmacies with acute pharyngitis, only about 20% of them tested positive for group A strep. And only those individuals received antibiotics. And this represented about a 40 to 60% reduction in inappropriate antibiotic use according to or compared to historical controls. And I put this in there because right now this is one of the very few interventions that I'm aware of that actually meets that reduction of inappropriate antibiotic use by 50%. And that accomplishes it now. And so if you're looking to meet performance measures in the future, sometimes we have to look outside the walls of our individual clinics or systems for partners that can help us meet those goals. So, my parting thoughts. Stewardship is not a lone wolf endeavor. We have to partner. We have to look for partnerships across health systems, and don't forget to involve the patient in these as well. Diagnostics, point-of-care diagnostics, just like they do on the inpatient side, are going to play a key role. But that data, again, like on the inpatient side, is only going to be valuable if we use it appropriately and in a timely manner. And you know your health systems better than anybody else. Not everything that works in one situation is going to work at your institution or your system. So we need to be aware of that, and we need to find ways to implement strategies that are going to be most beneficial in our settings. So I'll just part with these readings, and I think these are some good places to start. If you're looking at wanting to start doing some outpatient stewardship, review these readings. So with that, I will stop and take questions if there are any.
Thank you very much, Dr. Klepsik, for that fantastic presentation. A lot of great information. This is Jeff at the MHA Keystone Center. I'm running tech on the webinar in the background here. If there's any questions at all, feel free to type them in the chat. We have just a little bit of time here before the top of the hour. I did put our general email in the chat there, so please jot that down. If you think of any questions for the presenter or for us at Keystone here at any time, shoot us an email and we'll get back to you. As always, this recording, again, will be posted along with the slides on the MHA community site, and we'll send out a link to that in follow-up when that's ready. So we'll make sure to get all the resources to this group. Are there any questions out there today? All right, well, I don't see any questions coming in. So again, Dr. Klepser, thank you so much. Corinne, any parting words before we sign off?
Thank you, everyone, for joining. I really appreciate it. And thank you, Dr. Klepser, for the great presentation. Just as Jeff mentioned, if you have any questions, please email us at keystone@mha.org, and we will be sure to connect with Dr. Klepser and get these questions answered for you. But other than that, thank you very much, and you all have a great rest of your day.
Thanks. Bye-bye.